Hey guys, welcome back to my channel. Let's do a quick revision on gestational trophoblastic tumors. Okay, so gestational trophoblastic tumors are benign is complete mole, partial mole, and malignant is that trophoblastic tumors, partial trophoblastic tumors. Okay, choriocarcinomas, atypical placenta nodule that way. Okay, so epidemiology of GTT is Asians are seen, Hispanics and American Indians are seen. In Philippines, it is 1 is to 80. Taiwan's are also same. What are the risk factors? First risk factor is age. If it is less than 21 and if the female is less than 21 or more than 35, she have a double risk. Okay, less than 21, more than 35, she has a double risk. If the age is more than 40, then she have almost 10 times risk. Okay, less than 21, more than 35, she's a double risk. So remember age. Whenever you read about age, na, remember your age. Okay, if you are near to which age, then remember, okay, I have this much risk. Okay, that way. So less than 21 and more than 35 double risk, and more than 40 is 10 times risk. So generally what happens is the primary oocyte is 46XX. It undergoes meiosis 1 into secondary oocyte at 23X and first polar body that is 23X. So what happens in complete mole? This total 23X is there now. It will go into the polar body. So the secondary oocyte has a empty one. Okay, so empty one will go and freezes with the sperm. That way, that's where the complete mole is formed. Okay, so what is the recurrence rate of what is the second? Second risk factor. First is age. Second risk factor is if the female having previous history of mole. If she's having previous history of mole, complete mole is she's having risk of 0.9%, partial mole is 0.3%, and she's having history of molar pregnancy, so 20% risk of molar pregnancy in this time also. Okay, next is genes, genetics. So NLARP, remember NLARP is for molar. So NLRP, NLARP7 gene, it is located in chromosome 19. So just a quick revision. In SLE, what are the genes? I told the SLE. You remember SLE as Apollo stat. Okay, so Apollo 1 stat, and you have a DNase and DNase gene, and one more HLA-DR3. Okay, these genes are located on chromosome number 16. Here it is chromosome number 19. Okay, remember that. Now another gene is KHDC3N. See KHDC, I feel like कौन बनेगा करोड़पति type. Okay, so KHDC 3 lakhs, will get 3 lakhs rupees worth of money. Okay, so this kind of case DC is 100% mole, 100% mole. Okay, so I do a complete mole. What happens is this MTO will be fused with sperm and the sperm doubles up. Okay, so paternal chromosomes are only seen. Okay, it is sometimes what happens in 5 to 10% cases, two sperms come and fuses MTO. Okay, so there is 46XX more common than 46XY, and 46YY is not there. This is a question in latest INSA, this is a question. Okay, 46YY is not same. Coming to partial mole, basically Zona pellucida is there, na? You know Zona pellucida, it is the covering one which allows only one sperm to come on at one cycle. That Zona pellucida will be faulty. So when there is faulty, there's two sperms fusing with the 23X. So it results in here 23, here 23, here 23. So 69 triple X is coming. Okay, so what are the clinical features of molar pregnancy? First thing, 70% of the females will have vaginal bleeding. Okay, and specific sign is great like vesicles is seen. Along with that, there is anemia, hyperemesis gravidarum, hypertension, hyperthyroidism is seen mainly in complete mole of 1%. Okay, on examination, you see uterus soft. If it is more than period of gestation, it is complete mole. If it is less than period of gestation, it is just partial mole. Corpus luteal cyst also seen with complete moles, and with heart-related clinical features is like patient will be coming with vaginal bleeding and will say, धड़कन तेज से हो रहा है. So there is palpitations, there is tachycardia, there is sweating. Okay, and obviously people are they'll miss periods, so they'll do UPT. So diagnosis by UPT positive, but it's not pregnancy. On ultrasound, you can see no stop appearance. In partial mole, you can see the fetus also. Okay, and in partial mole, almost 40% of the partial fetus reach up to term pregnancy. Mostly they'll go in stillbirths only. Okay, coming to gestational. Yeah, gestational topoplastic neoplasia conversion in complete mole is 50 to 20%. Partial mole is 0.5 to 2%. This is also INSS question. So whatever I'm saying now, 46XY is not there, and this is also one of the questions. Latest in 2025 INSS repeat medicine questions. Okay, these two. Okay, coming to twins. Uh, what, yeah, if there is a twin. and there is a complete mole in one side. It can be it also looks like partial mole. How to differentiate it? By means of HPE only. Okay, karyotyping you can do karyotyping because partial mole you can go for 69 triple X, whereas in twins you have normal 46XX. Okay, and this what twins converting into gestational trophoblastic tumor is almost 46%. Okay. Investigations of how you work up of a case of molar pregnancy they'll give. So you'll add all the CBC, hematocrit, blood grouping, screening, blood matching, you'll arrange the blood, LFT, RFT, thyroid profile, you'll do this. Okay. Treatment of this suction evacuation, you'll go for IV cannon of 20 to 20 cause, spinal channel care you can use. Oxytocin can be started not before the procedure, during the procedure 20 minutes you start. Okay. Carmen's cannula is just 12 number size, and that MBA has 600 to 660 pressure and 60 ml of volume it is there. And we can give Mithergine, Carboprost, Misoprost also 800 to 1000 per rectally you can give. If she's RS negative, you'll give the anti-D injection. Okay, first time you'll give 50, second and the more you'll give 300. Beta HCG after 48 hours of suction evacuation, you'll do beta HCG and weekly you'll do every weekly. So you'll say, Matarani, now you have a suction evacuation done. You go home. Come after 1 week. So every weekly you have a blood test. Then you say yes, every week. Then she said, every week who will come. Then you tell the consequences. If you won't come and if there is any increase means you'll land up in cancer. Please, Matarani, please come every week. That way you'll counsel her. Okay. Uh, Less than 5 should be present. And after 3 weekly or whatever time, if it is normalized, then again you will tell monthly you come. Even then also she not settled. Okay, even if it is normal also you should say you must come monthly and get it done. Okay, FICO says that in partial mole if one month is okay. If 1 month sample is normal, then it's okay. Leave them. Okay. Contraceptives, if copper T is a category 4, you should not give. There is one immunohistochemistry marker that is P57KIP2. This is also INSF question. Yeah, this is also INSF question. See, P for partial, remember that. So P for partial. So P57KIP2 is present in partial mode. So complete mole takes about 9 weeks to get normal. Partial mode takes about 7 weeks to normal. And when you say persistent HCG, when you give chemotherapy in this, okay, there are four conditions. One, if beta H is more than 10% in 2 weeks, like 0, 7, 14 weeks, she's coming weekly, and her beta H is increasing by 10%. For example, she's having 1000, next time she's having 1100. So increasing by 10%, 10% every week. Okay, so then that means it is a persistent. If there is a thousand, for example, if she is having 10,000 and it is present 10,000 in the next week also, it's even constant plateauing also persistent this thing. In after 6 months, beta HCG positive. After HP also, on HP if there is choriocarcinoma features, then we'll give chemotherapy. Okay, how to differentiate complete partial mode? First, chromosomes. What is this XX? What is XY? Partial is triple X, XXY, XYY. Okay. Incomplete there is no 46YY. Remember that. Okay. On ultrasound you can confirm here it is a misdiagnosed with a threatened abortion. Fecal literacy are present in complete mole. See, complete mole is something like all the faltu lafada will be there in complete mole only. Okay, fecal literacy is present. Okay, HCG will be more in them. Medical disease like hyperthyroidism, hyperemesis gravidarium is present. Even converting into cancer, GTN is 15 to 20%. Whereas in partial, fecal literacy is rare. Beta is less than one. Like this, it is partial is something like a cool one. Okay, rare medical disorders even converting into cancer is 0.5% only. Okay, in complete you have no fetus, so all the F features are absent. So fetus is not there, fetal RBC is not there, even trophoblastic this thing also it is diffuse. Whereas in partial you have all F features like focal villus edema, you have fetus, you have fetal RBC, even trophoblastic proliferation is also focal FFF. Okay, I already told P57 IHC marker is P for P partial mole it is present, P for P. Okay, this is the short notes on quick revision on resistant to trophoblastic tumors, benign variety. Next I'll tell about malignant. But if you write these many points, now you will easily get 8 points for 10. Okay, thank you.